Dr. Dorothy, a lot of times we've talked about, is the correct diagnosis being made? Like, when it comes to restorative dentistry and what dentists already know, there's a lot of confidence in that. Cavities equal some sort of restoration, gingivitis, prophylaxis, pocketing, periodontal therapy, abscess, really clear endodontic therapy. Typically, can mean other things, but and crowding, orthodontics, those sorts of things are just very well understood. And then when you get down to things like fractinitis or vertigo, or when you're seeing the evidence of grinding, deviation or deflection, or wear on the teeth going on, a lot of times the diagnosis is made for that is diagnosed, or even
in dental school, we are taught, to basically look at the signs and equate it with a specific treatment. And so if we see decay, we will treat it with a restoration. We see a broken cusp, then we treat it with a crown. So this is no different. We are taught that if we see worn teeth and worn teeth and there's grinding, we were taught to basically prescribe a night guard. And so I did that for several years out of dental school. And it just happened that I did some orthodontics and I studied a little bit further, occlusion and things like that. So I kind of fell into it, studying TMD. But the issue is that we are so focused on the actual signs and looking at different signs and equating it with specific treatments that we may not be asking about actual symptoms that are arising from the actual signs, or the signs are actually the clues of the symptoms. Fractured teeth, bruxism, tori, limited range of motion, those are all signs of TMD that's underlying. So that's a different treatment that needs to be prescribed, but you need to ask a few more questions. So is there pain along with these signs? Is there tinnitus? Is there ear congestion? Is there vertigo? Is there headaches? It is our obligation to keep asking questions. It's almost like we have to rule that out. Just like, when doctors rule out, when somebody has high blood pressure, is there congestive heart failure, or when they have diabetes, which type of diabetes is it? Like, you have to keep asking questions. We don't stop at, okay, there's worn teeth, and so we just give a night guard. Like, we have to ask all these different questions to basically rule out certain things. But the unfortunate thing is that, we are just not taught these things to ask. So many of us, and I am victim myself, I was not taught to ask about tinnitus and ear congestion, vertigo, and headaches, and or treat those things, and which appliance and how to make it and what to do with it. So it was, and because I was not taught, I would stay away from it because it was scary to do something that I've never had experience with. So taking education and advanced classes is what I did, because I kind of I was interested in it, and I wanted to help patients, and I just saw the prevalence of it. I saw how many patients were actually affected with it. It is our obligation to basically not only look at the signs, but look at the symptoms and ask those questions to be the best at our scope of practice. And limited range of motion and deep curve of speed, asymmetry of the chin point, and condyles that don't look right and have already joint derangement that you see on a Panorex and is staring right at you. Those are within your scope of practice. I mean, who else would take care of it? A physician? No. An ENT? No. I mean, range of motion, where you have deviation, deflection of the jaw, like, who else would treat that? The treatment is appliance therapy. So oral appliance therapy, sleep disturbance, where, with appliance therapy, if they're CPAP intolerant, like it is us. We have to treat that. There's no other specialist. So basically, I'm saying that it's within our scope of practice. So we need to learn this, but the unfortunate thing, Liz, is that we are just not taught. And that's the unfortunate. It's our obligation more so too, not only it's just our obligation, because there's no other specialist that can do this, because the treatment is appliance therapy, and so we are the only ones that can, by law, make oral appliances, so it's yet another example where we are isolating and taking snoring, which is a sign, and we're saying, okay, let's give him an appliance, without really saying, what is this a symptom of? Because it's a symptom of a retruded mandible, okay? Most likely compressed mandible, a displaced disc. These are all TMD related things. So it's just yet another example where we are just jumping all over a sign of snoring or sleep disturbance. It's an indicator, okay, of a condition that's underlying, okay? So I dive in and I say, why is this happening? A person doesn't just have sleep disturbance. There is an underlying problem. And so it is our duty and our obligation and our ethical duty to the patient to discover why. And the reason why I start with TMD is very often when you place the mandible, when you just open up that VDO, bring that jaw forward, you eliminate that pathology. You put the mandible where it belongs and you correct that sleep disturbance. So, but you may not do that if you just do the sleep appliance because you arbitrarily place the mandible with a sleep appliance, where in TMD therapy, you specifically reposition the mandible. So it's a different therapy altogether. One is more arbitrary. The other one is very, very specific. Okay. And with the TMD therapy, you can actually very often, I would say 50% of the time, you can take care of it, especially if they're wearing the appliance at night, which they always do. The sleep gets better, in the snoring. So why would you not? I mean, they're so related, and the source of the sleep disturbance is the displaced mandible and all the TMD, the TMD condition. So that's the reason why I start with that.
Oh,
I approach it like this. When I see the signs that typically, most dentists would, or the way I used to just prescribe a night guard, I basically approach it like this. I say, okay, I see signs of TMD here. So what symptoms do you have? Do you have the headaches? Do you have the tinnitus? Do you have the ear congestion? Maybe not yet. Which symptom do you have? Because they will have those. Some of them, many of them, one of them, something, because it's physiology. When things are displaced and things don't, when there's dysfunction and things do not function in coordination, there will be pain. You can't avoid it. It's just to what degree. Okay. So when I see what you have on the screen on the left, okay, I ask, what symptoms do they have? Because I know they have them. They may not know it's related. I just say, okay, so I see that you have a bite. that causes headaches, tinnitus, ear congestion, vertigo, mandibular deflection, usually deviation, limited range of motion. This bite usually causes this. So what do you have? And that's when all this stuff comes out. Oh my gosh, yes, 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 I have ringing in the ears. I have headaches on a daily basis. That's when but you have to say it with conviction. Like you have to say it like you know it. Like you can't be like, do you have that? Well, maybe you have that. No, like this causes that. Like it's been proven scientifically. It's not maybe, it does. It equals. When I see a class 2, worn teeth, chin point off to the side, clicking, popping, I ask which symptom do they have? Patient doesn't want to bother you. You know, they're like, maybe it's not related. No, I say these things cause this. What do you have? And that's when it comes out. So it's almost like I want to prove myself right. Okay. So I'll do my exam intraorally and I'll see the signs, right? So I'm like, okay, this person has it. Now I just have to prove myself right. Okay. So I know the anatomy, I know the physiology, I know how it works. It works the way it does, the mechanism of action, right? So I look at the face, and the facial asymmetry is and the lower face height is your first telltale sign. And also the eye plane, the ocular plane, and the squinting of one eye, like that telltale sign. Okay. So I look at that, and then the chin point deflection to one side is usually the side that's compressed. So I say, do you have ringing on the right side? Do you have pain on the right side? Do you have congestion on the right side in the ear? And that's what, so I already know this. Like, I'm not looking to discover if maybe things are happening. I know they're happening because the anatomy is screaming at me, telling me this is happening. It's not maybe happening. It's like there, So, but that's something you learn, right? You learn this because like you need to look at enough faces, you need to study this. So when you study this, you know that like we should be symmetrical. And so when something is off to one side, like what happens and what should it look like? What should it feel like? Where should the pain be, right? So these are all things that like you learn as you do this. Okay. It's not hard. It really isn't. It's like patients appreciate it because nobody can connect the dots for them. And they're like, oh my gosh, now finally somebody knows why the ear is ringing. The ENT doesn't know what's happening because there's no infection and nobody can help them. So, it's wonderful. Like the gratification from this is enormous. Like who else is going to help these people? Because the treatment is appliance therapy. Like what we have to understand, it's not drugs. So it's not a physician. Like if it was drugs, then it'd be a physician, but it's not. Like Imitrex will only help the migraine so much, and then the debilitated, but it's like not helping the issue. Like it's not going to help the problem. Liz, you can speak for yourself how it helped you, and so nobody can. Appliance therapy is the treatment for myofascial pain and for relocation of your mandible where it belongs, period. So it belongs in a dental office. You just open and close your mouth a few times, without touching your teeth. Your mandible will go into the center. The teeth are holding it in pathology, and like I said, the patients love it. It's an appliance therapy. It belongs in the hands of the dentist. It's covered by medical insurance. Dental insurance also helps, in some cases. So it's pain management. Like who else is going to help these patients? We have to learn this, right? But we weren't taught. We were not taught. So Liz, when I teach my students, okay, my first challenge to them is to see how many of their night guard treatment plans they can convert to, not convert, but like diagnose into TMD. So what their first task is to basically like ask those further questions. How often do you have headaches? Do you have tinnitus? Do you have ear congestion, vertigo? Is there mandibular deflection? Is there deviation on range of motion? Is there limited opening? Is there abnormal findings of your condyle? Condyle should look like a drumstick. Anything other than that is pathology. Is there chin point, facial asymmetry? Okay, so if there is a yes, that is not a night guard anymore. Then we have symptoms of TMD. Now it's a different treatment. Okay, so we have signs of underlying derangement and dysfunction, but then we have symptoms of a TMD condition. So treatment is different. Yeah. So that's my challenge, because I think dentists have to, because, sometimes they're like, well, I don't have that many patients, because you're not asking, like when you ask and you say, okay, I see that your bite is the bite that causes these symptoms. Which ones do you already have? Because the rest is coming, because unless you make a change, it will just naturally progress to joint derangement 1, 2, 3, 4. Those are the stages. Everybody can look that up. So it's just a matter of time. It like doesn't stop. It's like a progression, with aging. So yeah, so you just say that, and then you ask the questions, and you will find how many people. It's like 75% of the population has this, so yeah.
Correlated to so many other areas of health and dentistry, like, when you see somebody with a high BMI, who guess that they're pre-diabetic or diabetic,
Of course,
or
high blood pressure. Yeah, absolutely. It's more the other way around. So like TMD patients are predisposed to sleep apnea. Okay, like 75% or higher. So it's so prevalent that like you should be looking at TMD, not at sleep people. Like it's the other, we have it all wrong, Liz. I mean, it's the other way around. You treat like pain, dysfunction, infection, or trauma. That's my model. Like, if, like I said, when I said that bite doesn't produce those symptoms yet, we don't have to do anything. Like, and it's kind of rare, but it's rare because usually by the time I get them, like, unless they're like 17, 18, like it's a lot of time genetic thing. And if they didn't have orthodontics, things are the way they were, right? So usually things don't change, and the anatomy stays that way, right? So things don't get better. So very rarely you don't have the signs without the symptoms, very rarely. But I don't, if you have to be ethical, I mean, obviously, right? So we treat dysfunction, we treat pain, we treat infection, trauma. Okay, so that's when we treat it. If they're not present, we don't treat it because they don't have the symptoms. You see what I'm saying? So there would be a case where I would give them a night guard. Okay.
Yeah.
Correct. Just to protect the teeth. Okay. From further destruction, because if they don't have any symptoms of pain. Yeah. Sorry to interrupt. It depends on what you're treating and which of the symptoms you're trying to shut down, right? So we treat the snap-on smiles if we're trying to open up the vertical dimension and also improve the smile. Patient can't, for example, proceed with, full mouth reconstruction, but they would like to improve their smile because the teeth were destroyed for one reason or another. Okay, so we can improve the bite, we can improve the smile, we can align the mandible and the maxilla, okay, to be discreet about it also. Yep. If you want it to look more natural, like the teeth, absolutely. Yep. If you're missing teeth, yeah, and then also if you're height, if you're vertical, if you're lost so much vertical that you need to almost like break up the vertical between the two arches, it may be difficult to handle that with a lower orthotic, because that vertical height would be just so great, right? So we can split that difference between the two arches. So that's the thing, like you can really customize the treatment to what the patient needs and what you're trying to accomplish. And I try to do the best, like what the patient needs and what I'm trying to do for the patient. For most patients, where I'm trying to manage the pain. Okay. And we do it on the bottom because it just seems to be the best way to decompress that joint. And we have a centric stop. So the maxilla is like the fixed thing in space, right? So what we want to do is have the movable mandible, okay, have almost like a well where that top lingual cusp, so maxillary cusp, will just return over and over and over. Okay, so it just seems to work better. Studies show for the decompression and for the masticatory and the kinetics of the mandible. Okay, if you do it on the bottom, and also if you're trying to advance the mandible. Okay, so we do it on the bottom, and you just want to make sure that you don't have like these really tall walls, because as the person is trying to go into those centric little stops, they're going to hit those walls, and then they're going to feel uncomfortable because it's not going to go into the center. So you really don't want these huge walls in anatomy. You really want these little pinpoint stops for this, but it does advances them, opens them up. They eat on these, they function with it, they sleep with them. You do have to take them out for 2 to 3 hours a day to ensure that your bite doesn't change permanently, unless that's what we're trying to do, change the bite permanently. Okay, so with any of these, the joint will have a tendency to remodel because it wants to remodel. It has been compressed and the condyle changed and it's angled like this. So once you decompress everything just has the space and is free to just kind of remodel, right? So it's a good thing for the body, but then the patient sometimes complains because the bite is not the same. So we always tell the patients to not wear it for a few hours a day, just so that they can return to that bite. I mean, they usually don't feel good returning to the bite, but it's just one of those things we want to make sure that they don't hold us responsible for changing their bite if that's not the intention. Okay, now many times it's my intention because I have debilitated patients. They don't want to be in that bad bite. So it's just whatever you're trying to treat or do. And then the first appliance is just like a sleep appliance. So sometimes I have a day appliance and a night appliance. This one is if the patient has very strong super hyoid muscles here, and anterior digastrics, and that are pulling the mandible back. So at night, we want to make sure that we're advancing the mandible and keeping the bite, the jaw forward. So we may make that as their sleep apnea device. And there's all different designs. I like this one. This is my go-to. It's a very flexible kind of a device, because the rigid ones, patients don't like them too much. They do hold the mandible, but it's so fixed that a lot of patients don't like them. So I start with this one. If they don't like it, if they have problems staying forward, then I'll go to one of the fixed ones. But I really like this one. It's made by Glidewell. It works really well. So again, you have to find out like what you're trying to treat, and then customize your plan to what you're trying to do for the patient. But really, I mean, you're sticking to like 3 options. Honestly, like that's my go-to design right here, so I don't think it's like too complicated.
And when you're initially diagnosing the patient,
Yeah.
you have a period of time where, the lab is fabricating.
Oh, yes. 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 Sure.
That day.
Yes. Sure. Sure. Okay. So one of the things that a lot of dentists get really nervous about is like altering the bite, and they get really nervous that, oh my goodness, like, what if it doesn't work? And, what if I make a change and something happens? So before you commit a patient to even an appliance like one of the three on the screen, something that I've developed over the years that works really nicely for pain management, and before you and it gives you an opportunity to just verify you're on the right track. And then you can discontinue if it's not working, which very seldom is the case. But what I found is if you just go through fabricating a deprogrammer, okay, it's a soft version of your appliance. What happens is it works really fast on pain management. Patients love it. It's cushiony, opens their bite up. It repositions their jaw into a comfortable position, and patients feel relief almost within days, hours, sometimes. I mean, sometimes, I have people like in a meeting and they have a headache or something, and I'll be like, okay, let's go in the back, and within hours they'll feel relief with a deprogrammer, and then I just transfer that bite into one of these appliances. So this is how like powerful that is, but also gives you multiple opportunities, because before you can make like 5 deprogrammers if you are like unsure or whatever. Like, you don't have to start like with this hard appliance and be, in with a lab for $100 or whatever the cost is. Like, you can make a deprogrammer that I teach like chairside, and they walk out with a therapeutic appliance that they're going to have pain relief, and then you fine tune it when you transfer the bite, and transfer it so that you can do one of your appliances. So it's not as hard as people think. You just, with years of like dedicating my career to this, like you find a way to make it easier, and really focus on what you're trying to do for the patient and not make it difficult. Yeah. Talk about your experience. So
We just have it in while we're doing things like being on the motorcycle. And I find when it's in, I'm fighting against it. Having it there.
Yeah.
Engaging, and it feels good. Is like clenching, which feels good.
Right. The vertical. Yeah. You have a home. I call that the home. Yeah. So the impact is tremendous, I would say. The way that I do the conversion is basically, and you mentioned the deprogrammer. I price the deprogrammer actually the same way I do the night guard, so that the patient doesn't feel like they lost anything. And the amount is actually within the 2,900. So what I do is I say, okay, so let's say, the deprogrammer is like $400. I'll say, okay, so the first part of your treatment is $400, and the remainder will be 2,500 if you feel better. You see, so I kind of break it up for them, and they are so appreciative because they know that, okay, so if this doesn't work, they haven't lost anything, because I say, well, it's the same as a night guard, so you would have spent that anyway, but it's the wrong appliance for you. So it's almost like they understand that like they would have spent that anyway on a night guard, but here they're going to try something that they should have, but if it doesn't work, they're not locked into it. So there's like benefit to the patient. So yeah, so that's how I do that. So that is probably the reason why I didn't even put that in there, but I kind of break up that 2,900 into two different appliances, the deprogrammer and then the orthotic. Okay, so the deprogrammer goes first, and then once the patient is happy, out of symptoms, then we do that orthotic. but it's similar to the night guard fee, so patient's happy. And when you start asking the questions and you think 75% of the population, when you look at your patients and you identify all the class twos with where, and you ask those additional questions, it will blow your mind how many patients have this. Like it's really overwhelming, and then when you start telling, like when the patient realize that you can help their tinnitus and you can help their vertigo and you can help their ear congestion and their ENT couldn't, it's almost like they're going to be begging you for the treatment, because if you think they haven't tried to get help, they have, but they can't get help. Nobody can help them except you. See, that's what dentists don't realize, the power of their profession, because the ENT couldn't help them. Their physician couldn't help them. And here is their dentist offering something, connecting the dots, so it will be very gratifying to you once you, but you have to say it like, the science. Just trust me when I tell you that those patients with the class 2 bites, the wear, the tori, the shift with the jaw, they have those symptoms. You just have to ask and say, you have to say it like that, those bites cause these symptoms. So which one of these do you have? Because the patient may be hesitant to say, oh, it's not from that, so you have to say these bites typically cause this, because then they will be honest with you. And when you say it like that, they will be so appreciative. I do this every day. So there's a trust factor here a little bit. But the science is irrefutable. This has been studied, and there's tons of studies behind this. And I do it all the time, and patients feel better. So
the reason for the night guard being presented to them. I think have high case acceptance because it doesn't have a complaint. I need this for a patient. And I know that it can come down to, the doctor's ability to enroll a patient and things like that. But I just overall, they're not as highly accepted as other things. However, when you've now identified somebody who has vertigo, who deals with ear congestion, I know for myself, like, I have some patients thank you, like,
yes,
because it's totally
they are, because they've right. Yes, and they've already they've already sought like assistance. They've already gone to professionals, and they've already gone to other physicians, and no one could help them, so they feel helpless almost. So when you're proposing a solution, they are so appreciative. They really are. It's really amazing, and I get testimonials all the time, how appreciative they are. So I feel like, it is a faith thing where, the dentists have to kind of trust me on this, but I feel like if they just try it, they'll know it for themselves. They just have to start asking those questions. That's it. And then they'll see when they make that connection, it's going to be unbelievable, because the patients are looking for the solution. And the only treatment is the appliance therapy. And that belongs in a dental office, it really does. There's nobody else that can help them, so.
It's such a critical benefit to patients. And I guess one of the most exciting things is all the ways that it helps patients that you're not even thinking about, people who have, myself personally, I have this electrical pain that made my finger randomly, and it's really strange, but turned it up too high, it gets your attention, right?
Yeah.
And to me, that's a telltale sign that I need to put my arm.
Yeah.
When I do, the system is connected to everything, and the muscles, and And it's just amazing the level of relief and help that a dentist can provide to their patients well beyond their dentition. By addressing the mandible relates to the tongue and all the muscles that go with it.
And so if they just look at my face, okay, and they see, it's very obvious that I have a chin point shift to my left, okay? And what question should we ask? Do I have tinnitus? Do I have pain? Do I have ear congestion? Do I have any of those? And guess what? And guess what? I do. On which side? On the left side. So I mean, it's just like that. So you don't say maybe, you say, which one do you have? Because when the chin point is shifted, you have symptoms on that side. So you just have to say which one. What do you have? Do you have pain? Do you have ringing? Do you have ear congestion? So I have ear congestion that is so annoying. I constantly have to go like that. You know, just annoying. And then when I put my orthotic in, it just drains nicely. And then my chin point is in the center. So it's physiology. Like, I mean, you know, it's just the structures, they love it to be in the center. And if they're not happy, and they produce certain symptoms, you know. So, and then with you, same thing, you know, we have a deflection over to the right over here. So I don't know if these are inverted pictures, but over to the right. So I would expect there being, you know, something over here on this side, right? And I don't know if that's, you have bilateral, yep. But I would first zone in on the right side, and I would expect there to be clicking, popping, some kind of pain, some ear issue. You see, there you go. Well, and if everybody just looks at faces like these two pictures, I mean, look at this, you know, and you look at your patients, and there's your example, and you just say, okay, so your bite is one of those bites that moves the face into asymmetry and should be producing symptoms of tinnitus, itchy ears, stuffy ears, headaches, facial pain, which one do you have? And if they like hesitant, and if they tell you no, then just say, all right, are you sure you don't have any? Because typically, like, you should have something. And then if they say no, say, okay, we're going to monitor everything. Every time you come in, I'm going to ask, because this is going to get worse. It's going to get worse, you know. It's degenerative. I mean, and the patient has to like feel it too. It's very important, because, you know, it's one thing if you're telling them there's something, and it's another when they're feeling it, you know, like, do you have clicking, popping, you know, is it hurting? No. Okay, let's check, because you know this chin point is shifted, there is popping, clicking, and there is a shift. You should expect there to be clicking. It's a displacement. You need to feel it. It's there. You need to find it. Okay, it will be there, guaranteed. So you have to, you know, find it, and you have to press until you feel it. Okay, so that, like, you do enough of them, practice on yourself. I mean, you got to put some pressure on it, you know. It's not a massage. You got to feel the joint moving, you got to feel the condyle moving. And then the patient feels it with you, and then they're like, oh my gosh, yes, you're right, yes, you know. So it's evidence-based. Yes.
An incredible technique, and it is so needed, and so.
No, I was there once, and it wasn't easy for me, but once you get a nice workflow, and get all those mysteries out of the way we were traditionally taught, which really doesn't make sense to me. You know, I understand it now. It's, yeah, the other side, and really treating the symptoms, not the signs, but the symptoms that the patients are experiencing, you know, and treating the symptoms. It makes sense, and I understand it. You as a layperson understand it. Stuff that you know, we were taught. I mean, I still don't get it. I don't. Honest to God, like, I'm trying to figure out like what they're trying to teach about the joint that is so disconnected that like it doesn't work in therapy. That's the thing. It doesn't work in therapy because they're not getting the results I'm getting.
You're doing thinking.
Thank you so much.